Welcome to our live webcast, Abdominal Wall Anatomy Revisited, the Rectus Sheath Block as the New Frontier in Abdominal Analgesia. Thank you for joining us. My name is Morgan Matthews. I am the Education and Program Manager at ASRA Pain Medicine. I will be your host for tonight's webinar, sponsored by PAJUNK. We are joined tonight by our moderator, Dr. Andrew Gray, Director of Regional Anesthesia on the Zuckerberg campus at the University of California, San Francisco, Department of Anesthesia and Perioperative Care. Welcome, Dr. Gray.
Thank you, Morgan. I wanted to thank ASRA and PAJUNK for putting this webinar together, and in particular, Morgan and Paulina for doing such a great job. It's wonderful to be part of this. Today, we're broadcasting live from the Zuckerberg San Francisco General Hospital, which is formerly affiliated with UCSF. That's where I practice clinical anesthesia along with my close colleague, Dr. Stefan Simon. As the moderator, I'll be following the Q&A. Please type in your questions as they arise, and we should have time at the end to address them. Today, we'll be talking about rectus sheath blocks, new approaches, new destinations, and what it's all about. Dr. Simon, it's time for your nice talk on abdominal wall anatomy revisited, the rectus sheath block as a new frontier in abdominal analgesia.
Thank you, Andy, for this fantastic introduction in here. My name is Stefan Simon. I work at the San Francisco General Hospital. We have some disclosures here to make. I'm an independent consultant for PAJUNK, and Dr. Gray receives royalties from medical publications. The content of the talk will, why will you talk about the rectus sheath block at all, how my journey was going to the rectus sheath, the history of the rectus sheath block. We will talk about current techniques, placing the rectus sheath block and as well the rectus sheath catheter. We talk about anatomy, the review of the anatomy, anatomic barriers, and the relevance for local spread. We talk about possible complications, shortcomings of the rectus sheath, and in a nutshell, at the end, I tell you how we do our rectus sheath block and rectus sheath block catheter placement. And I hope we have a fruitful discussion then at the end of the session. So you already read, I put the word frontier into my slide because there are still many, many questions to be answered to optimize this block and the catheter placement. And there are as well not really the recent discoveries public to all of us and that we know about the most recent discoveries. And we want to bring that to a broader audience. Frontier as well means flexibility and ability to travel along new paths. Dr. Gray and I, we're working at the San Francisco General Hospital. That's as well the hospital where the movie with Steve McQueen, Bullet, was shot in 1967. We are the level 1 trauma center for the city of San Francisco. We do 1,500 regional cases per year. That amounts for 2,100 regional blocks per year. We have a dedicated regional team in the main OR, and that consists of a block attending and a block resident. That's the second-year resident who rotates with us for 2 weeks. We have acute and elective abdominal cases, which are ideal for either epidural placement or as well for rectus sheath block or other blocks. We were confronted roughly in 2020 by the surgeon in terms of like, could we please avoid putting the epidural for their particular case because they do less invasive abdominal surgery and the epidural can hinder as well to have the patient discharged as early as possible. I think that's a trend all over the country and as well in the world that the epidural might go a little bit further down because of the amount of it due to the request of the surgeon. There are as well patients who have a contraindication to have an epidural placed because they're anticoagulated. And some of the patients wishing to avoid an epidural placement, and if we can offer alternative solutions for pain control. Of course, there are a couple of options, other options available. You could say, okay, I only use a PCA then extra on that, and I will be done. We could do a tap block or tap catheter as well. That's another regional fascial plane block. But the tap block is more for below the umbilicus then. And then paravertebral catheter block or single shot, a rectospinal block and catheter, and as well the QL block are a little bit more advanced block. And we wanted to use a block what really covers the midline and is as well easy to learn and can be done by all of our colleagues 24/7. So it's not just a single specialist on the regional team who can do the block then. So for me, there were many, many questions. So Andy said, like, we should really look into this block. We should really do that rectus sheath block, singular shot, or as well catheter. It is like the way to go. We need to find out how we can optimize that. And for me, it was like, there are so many anatomical barriers, the equipment at hand, the ultrasound quality and visibility, the high risk of the peritoneal puncture, the vascular puncture risk, and we didn't really had a target to go. I mean, we had like the posterior rectus sheath, but that is just a potential space, but not really a target. And when you have a regional resident just on their first day, and you're going down directly on the rectus sheath, you're always scared to go through the peritoneal, puncture the peritoneum. So what it is, a rectus sheath, most of the audience know it probably then here. It covers, it's a fascial plane block. It's covering somatic pain from T6 to T12. And it targets the terminal muscular branches and anterior cutaneous branch of the thoraco-abdominal wall then here, what we have then here. We see as well the subcostal tap block, what is nearly like a rectus sheath block. Here, the rectus sheath block itself, that's the target area, what we want to achieve, and here the tap block. If you put your ultrasound on the abdomen, you see that the picture, what you see on the ultrasound machine is slightly different in terms of what position on the abdomen you are. If you're higher up on the abdomen, you usually see as well the transverse abdominal muscle going under the rectus muscle. When you go lower, the transverse muscle goes to the left side, and you just have to see the rectus abdominal muscle. And you can already see here the double track line, as well, the tram track line, what we call it as well, what you can see in the first picture and the second picture. So that's basically the rectus sheath here and the fascia transversalis. If you go to the lower abdomen, you're aware that then the posterior rectus sheath falls away and you only have the fascia transversalis. Of note as well, the epigastric artery and veins come then into place then here. This is a nice picture as well, showing how close the bowel really is. And you can have an injury of the bowel very quickly if you go through the peritoneum. Here's the traditional approach, how we do it usually, how we are taught to do it currently. You put the transducer transverse, and you do a single shot either from medial to lateral or from lateral to medial. But then for me, it was always like, okay, we do one single shot, but we don't really look. We look at this, that it's the lift up of the rectus abdominis, but there's no guideline on the currently available on make it sufficient like that we have several, that we see several segments blocked. And we don't really know, does it really cover the whole rectus sheath? We know that we're putting local anesthesia in here, but that's currently all what we do. And I want to introduce you a little bit more what can be optimized. Here as well, the placement, how we are taught to do the rectus sheath catheter. It is a parasagittal view of the rectus, because you see the muscle longitudinal. You come in here with a big needle, the TUI needle, and you have to stop and look for that potential space here just above the rectus sheath. And you can already imagine, or I, being with a second year resident, but being on the block rotation on the first day, giving them a TUI needle and doing a rectus sheath catheter, that can be pretty scary, because you are always wondering, okay, hopefully I'm not going through the peritoneum and do a vascular injury then here. So we're talking about complication in general. Besides patchy or segmental block, there are potential serious complication to consider even in a fascial plane block like the rectus sheath block. And I already mentioned several times the peritoneal perforation, the perforation of the inferior gastric artery, bowel injury, vascular injury of the bowel, catheter knots are reported, and always local anesthesia toxicity. I want to quickly talk about a publication from Kwon out of South Korea. It's a retrospective study from 2017 to 2021 on single-shot rectus sheath blocks. And they looked back and had a number of 4,033 patients, and they looked on their complication rates then here. You see already here that 2.3% complication rate in total, mostly 88%, 88 patients had an extra sheath injection, and 8 patients had a more serious problem, a vascular injury. 7 out of them were inferior epigastric artery injury, and 1 was an mesenteric artery injury. The inferior epigastric artery injury causes a rectus sheath hematoma, and the inferior mesenteric artery injury causes a retroperitoneal hematoma. What we can see now on this picture. This is the rectus sheath hematoma. You see here really the bleeding in the muscle. And they were reporting that they didn't use color flow initially. And after they saw the hematoma in that area, they turned on the color flow and they could see really the inferior epigastric artery. In this picture, I want to demonstrate the retroperitoneal hematoma and the high vascularity then here in the peritoneal cavity. An interesting comment on this article was that they mentioned that the needle tip tracking is of primary importance in ultrasound guidance. However, the needle tip is often not visualized clearly in the vicinity of the posterior rectus sheath in our experience. So it was very interesting that they didn't always have total control of the needle when they did the block then. I'm going to just go quickly about the inferior and superior epigastric artery and their location in the rectus sheath. You already see them here. Here's the artery, and left and right are the veins then here, the inferior epigastric veins. When you are below the umbilicus, look at the right upper picture, where you are below the umbilicus, you see that the inferior epigastric artery goes from lateral to medial. Then there is a watershed zone, the way we usually do our block and usually are safe. And then there is the area of the superior epigastric area, artery, I'm sorry. So when you're going low, if you do a lower injection below the umbilicus, then here you're more likely to encounter then the inferior epigastric artery and have a higher risk. So this is always taught as well, that you need ultrasound for that and color flow to distinguish if there is any vascularization then there and the potential risk of bleeding. Here we see as well, when you look at the right upper picture, that the inferior epigastric artery can be singular, double, or as well 3 times. So there can be a high vascularization then of the abdominis muscle. Narayanan out of the UK published a knot in the rectus sheath. They had a practice that they would insert the catheter up to 15 centimeters into the rectus sheath, which they abandoned after that, having 2 knots in the hospital, and they haven't reported any more knots since then. And I highly recommend as well in a confined space to put the catheter only 5 centimeters, because otherwise you have the potential of getting a block, a knot then here. Concerning local anesthesia toxicity, I want to mention 2 recent studies by Bunkert and Bailey. They are excellent and I highly recommend to go over them. They did a recommendation about the absolute maximum infusion with plain blocks, and that was for bupivacaine 0.4 to 0.5 milligram per kilogram per hour and 0.5 to 0.6 milligram per kilogram per hour for ropivacaine. And you have to be careful with patients with extreme age, pregnancy, metabolic disease, cardiac disease, or hepatic disease you want to reduce. I just want to point out, these are the absolute maximum infusion what you should take for those patients. The recommended rate is probably half of that, and you can find it in the publication itself. Since I wanted as well to know a little bit more about the history and like a development of this block and how we can improve that, I looked how old this block is really, and it was developed by a surgeon, actually, a German surgeon, Dr. Karl Ludwig Schleich, and he used a 0.1 to 0.2 cocaine hydrochloride solution to anesthetize with a field block the abdomen when he did abdominal surgery then here. And his goal was as well, to have a relaxation of the abdominal wall and anesthesia for that. And he want to minimize as well the general anesthesia, which is sometimes necessary for those patients. And it was at that time in Germany done via a chloroform anesthesia, general anesthesia. And that was a horrible way to have general anesthesia because it had a very small safety margins, and there was nausea, vomiting, and complication, cardiac toxicity. The method was a little bit lost then over the years because we had much better general anesthesia gases. The development as well of the neuromuscular blockers in the 1940s didn't require any more extra medication for relaxing the abdomen. And Smith et al. In 1980 used the block as an additional pain management for laparoscopic surgery. And this was a blind landmark technique. In 2006, there was as well an ultrasound-guided rectus sheath block published by Wilschke, followed in 2007 by a surgical rectus sheath catheter block description by Cornish. and then followed by an ultrasound-guided rectus sheath block catheter placement in 2008 by Sandeman. You see as well here, I did a little bit of research on the internet then here, when really the publication of rectus sheath block took off, and it was, here you see it around 2008, 2010, and that correlates as well with the more abundance of ultrasound machines being available in the OR and using them for regional blocks then here. 2018, Routledge commented on the rectus sheath catheter analgesia for patients undergoing laparotomy, and he criticized that the current studies, what they have a really small sample size, that all the different techniques which are used, one are using a blind infiltration technique, there's surgical placement, there's laparoscopic placement, there's ultrasound-guided placement. We don't have a clear indication which one is best. He criticized as well, we don't really know what local anesthesia we should use it, and should we use continuous infusion or bolus infusion. The long-term impact on chronic pain is not known. And as well, how does it really correlate to other catheters like the epidural, thoracic epidural catheters? Then he suggested, then here, hopefully, it seems that the block is working, and does it work, but it could be optimized, and that development with ultrasound devices, needles, and catheter, this block and catheter placement could be improved over time then here. Highly anticipated was a comparison study between the rectus sheath catheter and the thoracic epidural catheter coming out of the UK by Anton Kriege. But the outcome was mixed, and we already thought the outcome would be more pointing in the favor of the epidural catheter because it covers somatic and as well visceral pain. So in comparison, the epidural catheter was much better as a rectus sheath catheter, although the rectus sheath catheter provided pain control to a certain level, but was inferior again to the epidural group. A small study out of Ireland in 2020 compared the rectus sheath catheter and the thoracic epidural catheter for abdominal vascular surgery. And they found that the pain scores were significantly higher in the epidural group than in the rectus sheath group. And there were as well several episodes of hypertension in the epidural group, in contrast to only 7 hypertensive issues in the rectus sheath group. So they were saying that it is at least equal to the rectus sheath catheter is at least equal to the thoracic epidural. Unfortunately, we don't know anything about the dosing of the rectus sheath block catheter and as well about the epidural solution for this study. Lakudava from India just recently published a comparison for infiltration of the abdominal wall in contrast to the rectus sheath block itself. And the results were very encouraging because the pain scores in the rectus sheath group were block. So they didn't place a catheter, they just did a block. The rectus sheath block group were lower than in the local anesthesia infiltration group. And there was also a significantly lower median dose of PCA morphine consumption and prolonged time to first rescue analgesic requirement in the rectus sheath block group. Now I want to go a little bit more detail in for the anatomical barriers and the equipment at hand. So Here we see the rectus sheath then here in all its glory then, and behind you see the rectus abdominis then already. And we know that the anterior sheath here is made out of the external oblique muscle and the internal oblique muscle until it crosses over under the umbilicus, and then the transverse abdominal aponeurosis is building up the lower part of the anterior rectus sheath then here. But we are only interested really in the posterior rectus sheath then here. And I have a little sketch here so you can see how the rectus sheath posteriorly stops at the arcuate line here, right here. So usually we think about a tubal structure of the rectus sheath, and we like as anesthesiologists tubular structure because it contains our solution. But here there is an opening, a relatively opening here, because the aponeurosis of the transverse abdominis and part of the internal oblique muscle go forward, and the back of the abdominal muscle is only covered by the fascia transversalis. Now, is that really a problem that we have suddenly only the fascia transversalis and that there is an arcuate line who might stop the solution? I was always under the impression that the arcuate line is always at the same place, but it is a highly variable structure in the human being, and it can be just 2 or 3 centimeters below the umbilicus, or just about the pubic bone then here. And it is as well not consistent in one human being. It can be different levels on one side in contrast to the other side. And as well, the arcuate line is different in terms of like a clear demarcation or a slight that the fibers of the posterior rectus sheath are slightly changing into the fascia transversalis. Here you see a clear demarcation line. So there is the posterior rectus sheath right here, and then it stops here, and then we have only fascia transversalis and the rectus abdominis muscle. And then here the fibers go slowly over into the fascia transversalis. So there's a transition zone in that terms. A study from Rojas injecting at several levels then here dye shows that the solution travels all the way to the pubic bone, what makes it more likely that the arcuate line is not really stopping our solution traveling to the lower end of the rectus abdominis muscle. Now we want to talk about the tendinous intersections then here, which I always thought like, okay, do we have problems with the tendinous intersection and we get only a segmental block then here? It was always thought that the tendinous intersection would be only from the to the anterior, on the anterior part, and there's no tendinous intersection to the posterior part of the rectus sheath. So it is basically a full thickness intersection was never thought before. It was thought that there is only an attachment of the tendinous to the anterior part, but there is no intersection of the tendinous or attachment of the tendinous to the posterior rectus sheath. In an abdominal cadaver study, it was recently shown that by Broly, that 18% of the cadaver intersections then were attached as well to the posterior part here. What made it the traveling of the solution in the back as a barrier. The tendinous intersection where they had a full thickness intersection were only seen in the midline. They didn't see it all the way to the back, but having a full thickness intersection makes it explainable that we have sometimes only segmental blocks. Let's talk quickly about the anterior costal nerve as well, because we are usually seeing these sketches that there's only one nerve coming out. Then here between the internal oblique and the transverse abdominis, it travels then forward above the rectus sheath, then here posterior rectus sheath, and pierces through the abdominis muscle, and then provides the anterior cutaneous branch and sensory. But if you look at this, then here, and I have here an ultrasound picture, there can be several pathways of that nerve. So the anterior part can be traveling already way at the edge here and provide the anterior branch, and the muscular branch for motor is coming, traveling then medial and then piercing midway. And I want to bring as well close that the rectus sheath and the nerves are more kind of a plexus than here. You have to think about the plexus like the tab plexus and the rectus sheath plexus than here. What you want to flood with your solutions, you get an optimal block. Does it matter if you do medial to lateral or lateral to medial? Yes, it probably matters, because if you do a medial to lateral approach, then you're missing those anterior cutaneous nerves. In contrast to if you inject from lateral to medial, you will probably get those lateral nerves and have a more complete block. This is supported as well by a study by Manacero in 2015. They did umbilical hernia repair, and they did the medial to lateral and injection, and it was only sufficient in 53% of the patients, and they always needed to do a subcutaneous injection to have a full block. So I want to switch gears in terms of like how it looks histologically. You see here the abdominal muscle, you see the anterior rectus sheath, you see the posterior rectus sheath, and here you see the nerves then here. So a very confined space, and you see a perimuseum then around here, around the muscle. Again, this is a transverse section, and this one is a longitudinal section then here. Here's the nerve, the posterior rectus sheath, and the fascia transversalis. Now, having known all of that, we started to do our rectus sheath blocks, and we knew that we needed to see the tram track, the double layer of the posterior rectus sheath and the fascia transversalis. We knew we wanted to go way at the edge of the rectus abdominis, and we wanted to ensure that we have like several muscle bellies then basically covering to get a full spread of our local anesthesia. So we did extensive scanning always when we did our rectus sheath block, and something surprisingly happened then. We discovered then a structure then here at the lateral border, what looked like a hypoechoic triangle, as we call it. So we suddenly saw a space where we can inject our solution, and you will see that here you have the tram track line, that is the rectus sheath here, and here's the fascia transversalis. You have the tendinous intersection, and here you have the muscle cephalad, and this is caudal then. And when you inject into that, so this is the outline now here of this lateral view and this hypoechoic triangle. And we were looking, is this only anatomic variation, or is this in several studies then here? And I want to show you a couple of pictures then here from our selection. You can see here as well a more flat triangle, and here the rectus abdominis muscle, the tendina. You can see here as well again, the rectus abdominis, the tendon here and the triangle. Here, more flat triangle. Again, here the muscle ballast, the tendon, and a space where you can inject. And here, a picture just like from a most recent scanning session where there was a huge triangle from that model what we used. The triangle is usually 0.25 centimeters or 0.5 centimeters high. And now you think about like, okay, is this triangle really only an abdominal variation, or is this really something what we have overlooked all the time? And I'm just want to show you a sonographic anatomy publication for 1993 by Ali. And if you look at it, the triangle was already there. No one has described it or has paid attention to it. And this is in correlation to the abdominal wall where those triangles were. I move forward now to a study what we have done then, publication in 2024. And that was driven by our regional resident, Balkan Thind, who was the main discoverer of this hypoechoic triangle. You see here the triangle. You see here the needle going into the triangle and the nice spread over 2 segments after injection. You see already here as well, there is a little structure here, what is probably the epimuseum of the muscle. And you need to go really in the correct space than here. What we did as well, we did not only a long axis view, a parasagittal view, but we did as well a transverse view after the injection. And you see that the local anesthesia is really nicely around the border of the muscle. So if the nerves are coming in, they're really bathing into that solution. You should get a really nice block then here. This is a video of a catheter placement here. We started to use first our regular TUI needles to do the catheter placement, but that was not really sufficient in terms of visibility. We switched then to a PAJUNK needle, which is a hypoechogenic needle. Then it's a 17-gauge needle and comes with an 19-gauge catheter, which has a closed tip and has 3 lateral openings. And I developed this one with PAJUNK. Now, let's talk quickly about advantages and disadvantages of the Rectus Sheath Block and the catheter. It can be applied at any stage of surgery, pre, interim, post-op. The application can be done easily in supine position. It's a basic block, and it can be used in anticoagulated patients. It has to be used with a multimodal pain regime. And it only covers somatic pain. And there you always have to be aware that there's a risk of last than what you can have, local anesthesia toxicity. Barriers could be scar tissue, suture material, or scarring in general would be hindering the opening of the fascial plane and as well the spreading of the solution. Let's put it together. How we do it and what anatomic landmarks we use, which catheter, what is our program, intermittent bolus, or do we use a continuous infusion, and which infusion we are using in general. So we recommend using a cranial to caudal injection or caudal to cranial technique with the hypoechoic triangle used for guidance during the injections. We usually have first a transverse view to identify really the rectus abdominis muscle. We want to see this tram track here of the posterior rectus sheath and as well the fascia transversalis. We rotate now our transducer to 90 degrees, and then we're looking for this hypoechoic triangle where we want to check. The beauty of this one is really that you have a target to go for instead of going for potential space. And you have as well the possibility to go with a large needle in there without being afraid that you're puncturing the peritoneum. You want to have that spread over several segments. We call it the Joker smile as well here. You do then the transverse view again to make sure you have sufficient spread around the rectus abdominis muscle in the sheath then. So going over that, that's a little progression of our procedure. So transverse view first with the ultrasound transducer, look for the tram track double line, rotate 90 degrees, look for the tendinaire intersection between the two intersections of the abdominis rectus muscle, look for the triangle, and then use your needle to go in the triangle and have lift off of the rectus abdominis muscle. Try for 2 or 3 segments, and then you rotate again to see sufficient spread then over 2 or 3 segments of the abdominal muscle. This is just a picture, recent picture of a patient after umbilical hernia repair and the sensory deficit what he had testing the skin. What about catheters in general? One lumen or multi-lumen? I think the discussion is still out there. We don't really know what is going. There's plenty of opportunity for research. I'm just showing here again different video what we shot with our catheter placement. And then if you ask me if we should do programmed intermittent bolus or continuous infusion. So we had our general guideline was, okay, we do continuous infusion then and top it up if necessary. But we needed several top-ups for our patient to have a sufficient pain control, and we will switch to ropivacaine 0.2% in the future, and we will have bolus every 2 hours on one side. So we will basically do 2-hour bolus on the left side, then another bolus in 2 hours on the right side. That way, with the alternating of the programmed intermittent bolus, we will reduce the plasma level of the local anesthesia in the blood. In summary, I just want to go over the main points then here. Always look for the lateral border then. If you don't see a sufficient spread, consider a second injection here, lower or higher. Place the solution or the needle cranial to caudal or caudal to cranial using the hypoechoic triangle. Use the alternating boli for bilateral rectus sheath block catheters. Think about, this is not the cornerstone, the rectus sheath block or catheter. Think about this is an extra tool what you have for multimodal pain control, especially as well for opioid-free anesthesia. And if you need visceral pain control, you might consider for doing a single shot spinal with morphine, what is done in the UK quite frequently, and that would cover your visceral pain 24-hour post-surgery. I want to end with a quote by Ludwig Schleich then here, to swell the cells anew for bold voyages of discovery. So there's many more things to do here to optimize this block. I hope I gave you some insight on how to improve this block and get a sufficient spread at the lateral border. I want to thank Andy Gray just pushing me for this block. He just publicized his 4th edition on the book of Atlas of Ultrasound-Guided Regional Anesthesia, and there is as well a section, capital 58 is on the rectus sheath block. I want to mention as well one more time, our publication driven by Balkan Thint, then what was published in 2024. I want to thank as well Paulina Thomas from PAJUNK, Morgan Matthews then from the ASRA, Lauren Hart from our admin service, and Ed Matthews from the IT service. And thanks for listening to this webinar. And I'm up for discussion here and questions.
Thank you, Dr. Simon, for that dynamic presentation. Those were striking images that you showed. I can see why the rectus sheath block is gaining in popularity. There's surgeons out there doing less invasive abdominal surgery, maybe not worthy of an epidural, but still we need some analgesic options for those patients. Couple of questions came up. One is in regard to threading the catheters. There were some knots that you reported. You limit the threading distance, is that correct?
Yeah, that's correct. We usually thread, first of all, we look where the most part of the incision is. Then here, if we want to go caudal to cranial or cranial to caudal as well. So to optimize the end tip of the catheter. So we are not stringent that we only can do cranial to caudal threatening or caudal to cranial threatening. That's one part. And we limit it usually to 5 centimeters coming out of that. Yeah.
Good. There was another thing brought up in the chat about the choice of rectus segment, and you know, above the umbilicus, below the umbilicus, above the abarquate line, below the arcuate line. It seems like a lot of things come into play. You know, stay in the watershed zone. You know, the higher segments may be more important for pulmonary function. What's your thoughts about going up or higher or lower in the sheath, superior or inferior?
So, you always have to be aware that when you're going lower, that there's a higher risk of puncture than here of the inferior epigastric artery. So you have to be aware in case you applying the block on an anticoagulated patient there. So that is one thing. The other thing is, I guess the block, if we optimize it, it has a high potential that it goes all the way off the abdominal wall. We already have seen then as well that people are doing a combination of the rectus sheath block and the subcostal tab block. And I think the subcostal tab block is nearly a rectus sheath block then here. You can as well consider if you do that you are doing 2 injections then here, a higher one and a lower one as well to get the segments as well. I think it has high potential if we are flexible and discover new paths. In the past, we only have done 1 injection. We're happy that we had liftoff, but we never checked it really, where did our solution go, and that we are really at the edge of the rectus abdominis muscle then here. If you look as well into like YouTubes, and people are always asking like, all right, we know that the nerves are coming from the side, and that's when we want to catch them. But our teaching is like we're going with the needle and place our solution medially. So I think the key is staying lateral and consider doing 2 injections as well.
You mentioned the rectus sheath block as an option for anticoagulated patients, but with some caveats that you needed to be more careful, perhaps staying in the watershed zone or applying color or power Doppler imaging to be more careful. Any additional concerns?
Yeah.
I think you did have a patient where you did alter your plan based on the the vasculature that you detect?
Right. There are some patients where I would be careful putting him in a rectus sheath block. And then if there's a high vascularization and he's anticoagulated, and I always put the color Doppler on to scan the rectus sheath just so that I'm not missing any artery in the rectus abdominis muscle then here. I think it's a safe block as long as you check for the vascularization of it. But I would stay away if there would be a high vascularization. And I was really surprised about that patient because with the color flow, it was nearly lightening up on the screen in the abdominal muscle, what I really didn't expect. And I was like, okay, here we could do a single shot, yes, then here, but a catheter, I would stay away then here. But if there are no vascular structures really visible, I use the color flow, I would be confident to put a rectus sheath catheter in the patient.
Yeah, it's an interesting space because it's shallow, but it's very difficult to compress. And if you get bleeding, it probably bleeds fairly freely within that space and probably hard to stop. I had a question about the block timing. The catheters are typically happening at the end of surgery, or you have patients in the ICU getting these things if they're intubated or even awake?
So we use it in different ways than here. Let me talk first about the rectus sheath block itself. Then here we do them on a awake patient, we do them on a sleep patient, and we do it postoperatively. So we do them basically at any level of care. And it's a really relatively easy to apply block because the patient has to lie supine. We don't have to move the patient really. Then with the catheters, we usually place them just before the wake up of the patient in the OR, but we have placed them as well in the ICU on sedated patient or awake patient as well. They tolerate that surprisingly well. I always thought like, okay, putting a rectus sheath block single shot would be uncomfortable for the patient, but it's not really. They tolerate it quite well.
I had a final question about the sonographic signs that you've been observing. You mentioned the importance of the hypoechoic triangle, identifying the space between the epimysium that invests the rectus segments and the underlying double layer. And you mentioned the smile that you get or bidirectional spread, but you also see downward displacement of the double layer. It's quite an elastic structure, right? It'll move quite a bit with the injection too.
Yes, so you want to do like pulsating injection, or you want to follow basically the spread of your local solution then here. Because as soon as you're opening the spread at the space, then more and more you can inject then here. You have to be aware of as well, like when you inject, your needle tip might come out of the space, the ideal space. And I want to just show that on this picture here as well. So the needle is right at the border here. So I think that's the epimysium here, that line here, that small line. And you want to keep being just above that posterior rectus sheath then.
So you keep the needle on the double layer
Yes,
during the injection,
yes,
or very close to it. And when the catheter comes out, it almost looks like a double barrel or something like that when it threads right along that double layer.
You can really feel actually the double layer, the rectus sheath, when with the TUI needle. Then when you're going in, you can actually play with it. What is a beauty, because that needle is so echogenic. It's lightening up. You feel confident as well with your resident to play a little bit with that structure when you're placing your catheter.
Yeah. There's clearly tactile sensations, but you're mainly emphasizing the importance of the sonographic guidance and the needle tip imaging, though.
Yes, I would definitely go for the ultrasound image. There's a little bit of the tactile there, and you can feel it. You can, as we call it, scraping along the posterior rectus sheath, but the image is the main thing what we're looking for.
Well, thank you, Dr. Simon. I think we'll turn it back over to Morgan and Paulina. If there's no further questions, I think the hour is nearly up here.
Thank you everyone for joining. Have a wonderful evening.
Dear interested audience, we have created this addendum responding to the requests from viewers of the webinar on the 6th of November and produced a video demonstrating the ultrasound technique for identifying the hypoechoic triangular space introduced in the webinar. Let's go. We emphasized in the webinar that the lateral entry zone represents the most reliable injection target for achieving multi-segmental anesthetic spread within the rectus sheath, thereby minimizing the impact of barriers such as the intersectionis tendinae or variations in the nerve pathway. The injection needs to be lateral under the rectus abdominis muscle itself and above the posterior rectus sheath. The posterior rectus sheath can be easily identified as the upper track of the tram line, and the tram line consisting of the fascial layers of the posterior rectus sheath and the fascia transversalis. Currently, three main approaches exist for the rectus sheath block. The classic transverse injection, lateral to medial at the lateral edge of the rectus abdominis, using a single injection per side. The second approach is a modified technique involving two injections per side to improve the longitudinal distribution of the solution over several abdominal segments. The third approach is a novel parasagittal approach described in the webinar and in our ANA publication in April 2024, in which the needle is advanced parasagittally into a well-defined hypoechoic triangle above the aforementioned tram line at the lateral border of the rectus abdominis muscle. In the now following video, Andrew Gray guides our incoming regional anesthesia resident who has not yet performed a rectus sheath block through the process of identifying the characteristic hypoechoic triangle.
We're looking at the rectus abdominis in transverse view. If we pull the probe laterally, we'll see all three heads, oblique muscles here, external, internal, and transversus. Going back medially again, we'll find the lateral edge of the rectus abdominis muscle and the underlying double layer of fascia. If we then rotate the transducer 90 degrees, we'll get a longitudinal view now looking at rectus abdominis segments. Moving the probe a bit more medially, we'll get that muscle back in view. And now we'll slide a caudal or cephalad to identify a triangle between adjacent segments. If we adjust the probe ever so slightly, we'll see the triangle between adjacent segments right here in the center of the screen. And we'll put that in the center of the screen. Good.
The hypoechoic triangle functions as well as an ideal target for placement of a rectus sheath catheter, since it is a parasagittal approach and the catheter will be placed at the lateral border of the posterior rectus sheath. This optimizes the spread of local anesthetic along the lateral border of the rectus abdominis muscles, right where the nerves enter the rectus sheath. In the left upper video, you can see a 2 needle just entering the hypoechoic triangle, and injecting local anesthetic creates space for further advancement of the needle. In the right lower video, you can see the smooth placement of the catheter right above the posterior rectus sheath. I hope the videos clarified our approach and technique for the rectus sheath block, and thank you very much for your interest, and please feel free to ask any questions.